Welcome to Pulse&Pressors, where critical care gets crystal clear. VA-ECMO is not simply oxygen support, it is circulatory rescue. We use VA-ECMO when the heart can no longer generate enough forward flow to perfuse vital organs despite aggressive conventional therapy. Today, we are breaking down exactly when VA-ECMO should be considered, the evidence-based indications, the bedside criteria, how flows are titrated, and the physiologic endpoints that tell you whether support is actually working. VA-ECMO drains deoxygenated venous blood, pushes it through a pump and oxygenator, and returns oxygenated blood into the arterial circulation. That means VA-ECMO can support both systemic perfusion and gas exchange. But the key principle is this: VA-ECMO restores flow. It does not fix the heart, it buys time. Time for myocardium to recover, time for revascularization, time to treat myocarditis, time to stabilize post-cardiotomy shock, or time to determine whether the patient needs transplant or durable mechanical support. That is why patient selection matters so much. The trigger question is simple: is this patient in refractory cardiogenic shock despite appropriate therapy? VA-ECMO should enter the discussion when hypotension persists, lactate rises, urine output falls, mental status worsens, vasopressor or inotrope requirements escalate, and there is still evidence of low cardiac output despite aggressive management. This is not for isolated soft blood pressure. This is for shock that is failing conventional rescue. Modern ELSO guidance supports VA-ECMO consideration in severe refractory cardiogenic shock when the process is potentially reversible or bridgeable. The highest yield VA-ECMO indications are severe causes of circulatory collapse that are potentially reversible or bridgeable. That includes acute myocardial infarction with refractory cardiogenic shock, fulminant myocarditis, massive pulmonary embolism with shock, advanced heart failure as a bridge to decision, refractory ventricular arrhythmias with shock, selected extracorporeal CPR patients, and severe cardiotoxicity. And for the cardiac surgery world, one classic indication needs to be named clearly: unable to wean from cardiopulmonary bypass. This is the patient in the operating room whose heart cannot separate from the pump, despite inotropes, vasopressors, volume optimization, rhythm correction, and surgical troubleshooting. In that moment, VA-ECMO becomes the surgical safety net, a bridge out of the operating room and into controlled ICU resuscitation. The key is not simply that the patient is critically ill. The key is that there is a meaningful rescue pathway: recovery, revascularization, thrombectomy, transplant, durable ventricular assist device, or at minimum, a bridge to decision. Without a destination, VA-ECMO can become a bridge to nowhere. VA-ECMO works best before shock becomes irreversible. The practical GO criteria include persistent low MAP despite support, rising lactate, low cardiac output, worsening renal or hepatic function, cold extremities, poor urine output, escalating vasoactive requirements, and ongoing evidence of end-organ hypoperfusion. But one question matters more than all the others: is there still recoverable physiology? If severe neurologic devastation or irreversible multi-organ failure is already present, VA-ECMO may prolong dying instead of rescuing life. That is why timing matters. VA-ECMO is powerful, but it is not benign. Major contraindications or severe warning signs include irreversible neurologic injury, terminal disease without a bridge option, uncontrolled bleeding, severe aortic insufficiency, unrepairable aortic dissection, severe vascular access limitations, prolonged no-flow arrest, and advanced irreversible multi-organ failure. Severe aortic insufficiency is especially dangerous because retrograde ECMO flow can worsen regurgitation back into the left ventricle, rapidly increasing LV distension and pulmonary edema. The question is not simply, can we place this patient on ECMO? The real question is, can ECMO realistically get this patient somewhere meaningful? Now let's address the most misunderstood part of VA-ECMO management: how do you actually titrate the pump? First, do not think of VA-ECMO like a pressor that can simply be turned down to zero. In peripheral VA-ECMO, the pump must generate enough forward pressure to overcome the patient's arterial pressure and maintain forward circuit flow. If RPMs are dropped too low, the risk is inadequate flow, circuit stasis, backflow, and thrombosis. The exact minimum safe RPM is pump-specific and center-specific, so this is not a universal number you memorize. It is a safety principle. Never arbitrarily dial VA-ECMO flow to 0. Once support is initiated, flow is usually advanced stepwise toward a calculated range, often around 50 to 80 milliliters per kilogram per minute, or roughly 3 to 5 liters per minute in many adults. But the flow number is not the endpoint. The patient is the endpoint. You titrate flow to restore MAP, clear lactate, improve urine output, improve perfusion, maintain adequate venous oxygen saturation, and reduce vasoactive burden. A common MAP target is 65 to 80, but the target must be individualized. Feed the pump, balance the pressure, protect the ventricle. This is one of the biggest VA-ECMO traps. More flow is not always better. Peripheral VA-ECMO returns blood retrograde up the aorta. That restores systemic perfusion, but it also increases afterload against the left ventricle. If the ventricle is too weak to eject effectively, the aortic valve may barely open or stop opening altogether. LV end diastolic pressure rises. The ventricle distends. Pulmonary edema worsens. Blood flow stagnates inside the ventricle, and thrombus risk increases dramatically. The bedside question is not simply, what is the ECMO flow? The better question is the patient perfusing and is the ventricle unloading? VA-ECMO may improve systemic perfusion while silently worsening LV distension. That is why echocardiography is central to management. Consider LV unloading when the aortic valve barely opens. The ventricle enlarges, pulmonary edema worsens, pulse pressure collapses, filling pressures remain elevated, severe mitral regurgitation develops, ventricular arrhythmias occur, or there is concern for blood stasis and thrombus formation. Unloading strategies include Impella support, intra-aortic balloon pump counterpulsation, surgical LV venting, septostomy, or carefully selected inotropes to promote native ventricular ejection. Perfusion without unloading can still fail. Peripheral VA-ECMO creates a unique oxygenation complication called differential hypoxia, also known as Harlequin Syndrome. This occurs when native cardiac recovery begins while pulmonary gas exchange remains severely impaired. The recovering ventricle ejects poorly oxygenated blood toward the brain and upper body. At the same time, the ECMO circuit pushes highly oxygenated blood retrograde toward the lower body. These circulations collide at a watershed zone within the aorta. The lower body may appear well oxygenated, while the brain and coronary circulation remain hypoxic. That is why right radial monitoring is critical. Right radial arterial line, right upper extremity pulse oximetry, right radial arterial blood gas, and cerebral NIRS if available. In VA-ECMO, the best saturation on the monitor may be measuring the wrong circulation. Now separate two things people often confuse: mechanical titration and pharmaceutical titration. Mechanical titration means adjusting RPM, blood flow, sweep gas, and oxygenator FiO2. Pharmaceutical titration means adjusting vasopressors, vasodilators, and inotropes. These knobs interact. When you increase ECMO blood flow, systemic perfusion may improve, but LV afterload can also rise. That means you cannot titrate flow in isolation. If excessive SVR is creating an afterload wall, you may need to reduce pure vasoconstrictor burden when clinically safe. But do not blindly remove pressors from a crashing patient. The goal is adequate MAP with the lowest harmful afterload. At the same time, selected patients may need inotropic support, such as dobutamine, epinephrine, or milrinone, to preserve native ejection and help the aortic valve open. Now the gas side, sweep gas controls CO2 removal and pH. Many protocols start sweep near the blood flow rate, often close to a 1-to-1 relationship, then titrate based on PaCO2 and pH. But sweep is not locked forever to flow. Blindly increasing sweep can drop PaCO2 too quickly, causing alkalosis and cerebral vasoconstriction. Blender FiO2 controls oxygenation leaving the oxygenator. And the ventilator still matters because it determines the oxygen content of blood ejected by the native heart. Match the knob to the physiology. Do not use the wrong knob for the wrong problem. Every day on VA-ECMO, ask one question: are we winning? Not. Is the circuit flowing? Weaning means lactate is clearing, vasopressors are decreasing, urine output is improving, perfusion is improving, mentation is improving, and liver and kidney function are stabilizing. Echocardiography should show either myocardial recovery or adequate unloading. There should not be worsening pulmonary edema, severe bleeding, progressive hemolysis, limb ischemia, or irreversible organ failure. The circuit number is not the outcome. The patient is the outcome. VA-ECMO is not a parking lot, it is a bridge, and every bridge needs an exit. The first 24 hours are about rescue perfusion, restoring MAP, clearing shock physiology, correcting acidosis, and preventing immediate death. By days 2 and 3, the question becomes, are the organs stabilizing? Is the lactate falling? Are pressors coming down? Is the left ventricle unloading? Then comes the critical decision window, days 4 through 7. This is often the peak window where myocardial recovery, weaning readiness, or escalation planning becomes clear. If the patient is not recovering by this point, the team should be actively asking, do we need durable ventricular assist device? Do we need transplant evaluation? Do we need a different unloading strategy? Or are we approaching non-beneficial support? Because once VA-ECMO pushes into week 2, complications begin to accumulate aggressively. Bleeding, infection, hemolysis, thrombosis, limb ischemia, consumption coagulopathy, progressive multi-organ failure. So the rule is simple. From day 1, define the exit. Recovery, weaning, ventricular assist device, transplant, or withdrawal. VA-ECMO buys time, but time on ECMO is never free. VA-ECMO weaning begins when the underlying cause of shock is improving. Lactate should be improving. Vasoactive support should be lower. Pulse pressure should be adequate. The aortic valve should be opening. And echo should demonstrate meaningful ventricular recovery. High-yield echocardiographic targets are commonly used to help determine readiness. Your left ventricular ejection fraction should generally exceed 20 to 25%. Your aortic velocity time integral should usually rise above 10 centimeters. And your mitral lateral tissue Doppler S' velocity should generally exceed 6 centimeters per second. During a weaning trial, flow is gradually reduced while carefully monitoring MAP, pulse pressure, lactate, filling pressures, oxygenation, and echocardiographic performance. The key principle is simple. Weaning does not test the machine. Weaning tests whether the patient can survive without the machine. Here is the VA-ECMO decision algorithm. Step 1. Is this refractory cardiogenic shock? Step 2. Is there end-organ hypoperfusion? Step 3. Is the process reversible or bridgeable? Step 4. Are there major contraindications? Step 5. Can we cannulate safely? Step 6. Can we restore perfusion while protecting the left ventricle? Step 7. What is the exit strategy? That is VA-ECMO in one sentence. Rescue flow. Protect the ventricle. Define the exit. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.